Good morning, everyone. First, let me thank for this invitation. I'm very happy to be here in these days of sports and research, of clinical discussion. So my talk is about physical activity in renal transplantation. I will discuss about everyday physical activity, not exercise, the activity of every day in the usual life. The mortality, the cardiovascular mortality in renal transplantation is higher as compared with the general population, much more in younger people. And the reason of this difference is mainly the CKD, the chronic kidney disease, kidney failure, which is associated with a number of either traditional but also non-traditional cardiovascular risk factors. A number of conditions that are typical of CKD. And among these factors, of course, there is also one of the major modifiable is, of course, the physical inactivity. And in renal transplantation are present many of these modifiable traditional risk factors. But there are also present a number of specific factors related to transplantation. The CKD itself, the diabetes of new onset during transplantation, and the drugs, of course. So the question is, which is the role of an healthy lifestyle, physical activity and weight control in the control of all these factors? We know in the general population that there is a relation between physical activity and a number of these intermediate outcomes. Physical activity has a direct impact on a cardiovascular outcome, but also may improve the control of blood pressure, glycemic control, lipid profile, has an impact on obesity and on restoring the functional status. We don't know exactly if is it true also in renal transplantation for most of these points. But the hypothesis is that physical activity may impact either directly or through the control of these cardiovascular risk factors on the both kidney and patient outcome. These have to be proven. Now the question of the point of our interest is to try to define which is the amount of daily physical activity in renal transplanted patient. Are there information on this point? Yesterday someone told us about the guidelines. This is the KDIGO guidelines. And the suggestion is to undertake a physical activity, of course, compatible with cardiovascular health and tolerance, aiming at 30 minutes for 5 times a week, but also to achieve an healthy weight between 20 and 25 of BMI, and stop smoking. In renal transplantation, we do not have many data, and most of these data are not consistent because the studies have few patients, are not controlled of short duration, and mainly the physical activity is not measured but is estimated by questionnaires, so a self-reported physical activity. And so as a subjective measure is almost inaccurate. In addition, we don't know, we do not have much information of the determinants of physical activity in renal transplantation. This is important because besides, of course, the knowledge of the barriers to physical activity, it's important to know the individual factors against the physical activity, so to plan specific intervention. And therefore, the purpose of the study, of our study, is to evaluate the objective amount of either duration or intensity of everyday physical activity, but together with the body composition and nutrient intake, which are linked with physical activity in a most wide view of healthy lifestyles. This is a cohort study, a controlled study. We studied consecutive non-selected patients with a stable renal transplantation for at least 6 months without any acute disease. And we used it as for controls cohabitants, spouses, companion, mother, father, sons. Because this subject lives in the same socioeconomic status and cultural status, have the same habits, live together. So the thought was that many of the barriers, some of the barriers we already discussed, are not present or are present the same way in the controls as in the patient. We measured the physical activity with an accelerometer, which works works in a free living context, measuring the number of steps and then the duration of physical activity, but also the intensity of physical activity. And this measurement was taken together a comprehensive evaluation of nutritional status, body composition, and nutrient intake. The group of patients, of transplanted patients, had a similar gender distribution, age with respect to controls. Low diabetic and low cardiovascular, previous cardiovascular events with a quite low Charlson index. So this is a group of quite young patients with low comorbidities. We have just heard that comorbidity is one of the major barriers in this group of patients, low comorbidities. Also, the functional status was quite good, except for the Carnoxy index, which was lower. The Bartel was exactly the same of control. So, low morbidity and well functional status in this patient. The educational was similar, was different as controls, because this patient in the majority had a middle education. It was reduced to the high-level university education. It was similar, the marital status of this patient, with respect to controls. There was also a difference in the employment of the patient. More patients with respect to control were unemployed, and also more patients were retired with respect to controls. They had the same age, and more patients stayed at home. So in the whole, there was a larger number of patients with respect to control without an active work, so they have time. This is not a barrier in this case. And this is the amount of steps in our population. Patient in general, it was in the mean. The number of steps was not very low. 9,000 for patient and 11,000 for controls, but it was different among the two groups. And when we look at the distribution separated for gender, most of the patients were under the threshold of 10,000 steps per day. 67, 68 females and males respectively. And looking more inside in this point, we found that 16% of patients were completely inactive, were sedentary. Half of patients had a low active life, and only 33% of patients were active subject. I repeat, we are speaking about patients with low comorbidities, middle age, and it seems without major barriers to do physical activity. Also the intensity, here is the duration of physical activity of moderate degree. It was different with respect to control subject. It was almost 40% lower in the transplant patient. Another aim was to try to identify some factors which may impact on the physical activity, and the amount of physical activity was related to gender, to age of the transplantation, with the functional status, while the intensity was only related to the functional status. But the only one modifiable factor we found related to the physical activity was the body weight and therefore the BMI. This is the relation. The higher was the body weight, the lower was the physical activity, irrespectively of age or gender. When looking at the body weight, the BMI was similar to the controls, but it was high. And 1 over 3 patients, only 1 over 30% of patients had a normal body weight. 40% of patients were overweight, and 22% were obese. This was similar to the control group, but only 1 of 3 patients was in the normal suggested range. Also ascertained the smokers. A number of patients stopped to smoke, but almost half of the patients that previous of the transplantation were smoking continued to smoke. So this is a point that can be improved. When looking at the body composition, this is an interesting point. The waist circumference, this is a measure of fat, was higher in the patient, and as a consequence, result also the ratio with the hip circumference. But the fat mass, it was even slightly reduced in the whole body, as measured at the arms with the circumference and the skin fold, and as measured by bioimpedance. So the result is that there is an abnormal distribution of fat in patients with respect to controls. And the asterisk and the minus without brackets represent the correlation with the physical activity, the number of steps. And this unusual fat distribution in this patient was related to the amount of was inversely related to the amount of physical activity. There was not a difference in the fat mass, in fat-free mass, in lean body mass, which were similar. So also this is not a barrier. And we also measured, here is not represented the, it's here, the hand grip. So the muscle trend it was also similar, and it's well preserved in our patient. The diet of this patient. They ate a quite adequate amount of calories. This was related to physical activity, but when correcting the amount of energy to the body weight, this relation disappeared. I mean, the number of calorie for kilo did not correlate with physical activity. So this positive relation depends on the body weight, of course. The distribution of the energy intake among the major macronutrients was quite normal and not different with respect to controls. The intake of proteins is not low, but it is not high. 1 grams per kilo is completely within, in the middle of the suggested amount of protein for CKD patient. Our patient ate a quite large amount of salt. 10.5 grams of salt measured by 24-hour urinary output is high. It's like in the normal population, which is already high. We also measured, estimated the salt intake by the food diaries. This is the difference. It depends on the fact that this salt is the only one contained in the foods, not taking consideration the added salt or the hidden salt in the foods. And there was a difference. So maybe there is some attention by the patient to the salt intake. But even though in the general the amount of intakes were similar, the composition of the diet was different. Indeed, our patient ate a much higher amount of acids and a low amount of fiber. And both these factors are related. There are a number of papers of evidence, of recent evidence that correlate these factors to the progression of renal disease. So all these factors did not correlate with the physical activity, but of course the nutrient intake has a correlation with physical activity. We don't know the direction and the exact relation, but the diet of this patient may be improved. So in the whole, looking at the lifestyle, we have that 2 out of 3 patients with stable renal transplantation are under the suggested threshold for physical activity. And at the same time, and this low physical activity is mainly related to the high body weight, even though 2 out of 3 patients are above the threshold for normal body weight. And also the body composition is abnormal with an abnormal body fat distribution and high sodium and phosphorus intake and low fiber intake. And finally, looking in the wall at lifestyles, some patients stopped to smoke, but almost half of the patients did not smoke, stopped to smoke. Which is the point of view of the patient. We try to compare the objective measure of physical activity during the daily activity with the questionnaire. This is a questionnaire, the EPIQ. And the patient feels he has an adequate or high physical activity. So there is a difference between what really happens and what the patient feels. This is a gross analysis. We have to look with more attention inside to this analysis and make some correction. But the first gross result is that there is a difference between the perception of physical activity and what the patient do. This is the summary of what I was saying before. The intention is different from the practice. So my conclusion is that in stable renal transplanted patients, the physical activity is reduced in both duration and intensity, at least in 2 over 3 patients. And the perception of this activity is overestimated by patient. The low physical activity in renal transplantation is related to several unmodifiable factors, age, transplant duration, comorbidities, also renal function and functional status, but the major modifiable determinant is the body weight. But many patients are overweight or obese. And this is a new point. Within this obesity, there is also an abnormal distribution of body components. Not all the patients stopped to smoke. So, I'm going to the conclusion, or I have concluded, but I would like to point out these 2 points. This is what happens in the dialysis facility around the world. The offer of exercise programs is very low, except of Sweden and somehow of Germany. In most patients around the world, around 10% of centers, if we can see 10% of patients can receive an offer of physical activity or support to their physical activity. And at the same time, also the patient is not, it represents in some way a barrier, because it's not very happy to do physical activity, at least looking at the result of the study. Thank you for your attention.